This is an e-Impulse miniseries, Push Dose Pearls, with your hosts, Sarah Medeiros and Julia Magaña.
Welcome back to another episode of Push Dose Pearls. This is our ongoing miniseries of brief podcasts that addresses the questions that we all have regarding medications in the emergency department. And once again, we are here with Chris Adams, our ED clinical pharmacist at UC Davis, and our very own e-Impulse pharmacist. And today, we're going to be talking about intranasal medications in the ED, one of my favorite subjects. Chris, welcome back.
Thanks. Let's talk about picking noses.
Oh, yeah, baby. This actually is a topic that I really enjoy talking about because I don't think that there is a shift that goes by that I don't order intranasal meds in my kids. So, Chris, I am super glad that you're here to give us some tips. First of all, why do intranasal meds work so well?
So first of all, I think the easy answer here is the surface area of the nasal passageway provides an excellent opportunity for medications to be absorbed through that mucous membrane. And in addition to that, there's minimal barriers to medication administration, and it really helps to expedite care of a patient when you're really struggling with access or they may be resistant to the idea of access or peripheral access.
Yeah, I call it the nose-brain pathway. That's my own term. But it is also a lot safer, right? It's a lot safer for administration for our staff because there's no needles that are involved, and it's safer for our patients and faster than oral. So I'm a huge fan.
There's a lot of opportunity here, and I think that even as time goes on, we're still finding newer ways to utilize intranasal medications and identifying other medications that might be useful through this route.
Right. I love asking that question. Like, could this go through the nose? Can we pick the nose?
So which meds can we use intranasally?
So the commonly utilized medications are naloxone, Versed or midazolam. Fentanyl is commonly given intranasally. Ketamine, even though we don't practice it in our shop, that's an option. We can utilize ketamine intranasally. And then a far more uncommon option, especially within the emergency department, maybe more common upstairs, is the use of dexmedetomidine or Precedex.
Yeah, we actually have used that in our emergency department for kids, for sedations, for like brief procedures that are non-painful. And I think it is a good option. But what are some of the indications for why we should use the nose versus intramuscular? Like, let's just go for intranasal midazolam. When should we use that versus intramuscular for seizures?
Especially in a situation where you're working with public or individuals who are not healthcare professionals, administering medications with a needle via an intramuscular injection, that poses some logistical challenges. And so it may not be the fastest option for administration of medication. And as we all know, the administration of these medications to break seizures is very time sensitive. And so if we can break down those barriers for medication administration, that's a very helpful option. Further, in a situation where you don't have a seizing patient, administration of an IM medication, it may be very challenging and actually may be very traumatic for those patients to administer this large needle into their muscle.
Talk to me about when we might use an intranasal medication in, for example, somebody with a sickle cell pain crisis.
Sickle cell pain crisis patients, they struggle with pain, and emergency departments in some settings are not a streamlined approach to patient care. What I mean by that is that there are lots of barriers, there's lots of steps in order to get a patient an appropriate medication. And so timeliness, depending on the medication, may not be the first thing on our mind. So for this example you're giving, a sickle cell pain crisis, these patients often run into numerous barriers in order to get appropriate medications started. And so even though the dose that you can administer via the intranasal route may not be the absolute appropriate dose for that sickle cell patient because it's so variable, at least getting the process started with a small amount of pain relief is really going to be helpful, not only in addressing their pain needs, but also building trust with that patient.
Yeah, I love intranasal fentanyl for my patients with sickle cell pain crisis, because it is faster, and I can actually put that order in while they're coming back from triage. And I do go back and have that discussion with the patient and let them know that this is an option and kind of decision share with them on that. But there's some interesting data that just came out from PCARN just here in 2023 that showed that it was associated with rapid onset. It was easy to give, and it was a feasible option for children with a sickle cell crisis in the emergency department. And so I think it's a great option for helping to get them medication options faster.
The only trouble that we run into with intranasal medication is the volume. We're struggling here with how much we can actually put into the nasal passageway. Generally, the commonly referred to volume is 1 ml per nares. So in that situation, you're really restricted in the amount of drug that you can give. Now, you can repeat that dose, but really how much is being absorbed is questionable. So again, the maximum you can give per nasal passageway is 1 ml.
So we don't really know what that sort of washout period of your nasal mucosa is in terms of when you can give things again and have it be effective?
It depends a lot on the patient and what they're dealing with. If they have a lot of postnasal drip already, how small or large the patient is. So generally, we think of it as being like 5 to 10 minutes of a nasal washout, but it really depends on each individual patient and what they're presenting with.
What about our other favorite medication, ketamine?
Ketamine certainly can be utilized via the intranasal route, and this might be an excellent option for a little bit of pain relief or anxiolysis associated with imaging, or even potentially providing enough dose, depending on the patient, to provide a procedural sedation. So it definitely is an option out there, and I think that it's just a little bit slow of an uptake associated with the use of this medication when compared to our other more commonly utilized medications such as Versed, fentanyl, and naloxone.
And why is that?
I think that in general, ketamine, especially outside of the emergency department, is still considered this like high-risk medication. It provides a deep level of sedation, and so it requires, in most situations, a provider who is credentialed for deep sedation or procedural sedation. And so in a lot of situations, the dose really does matter, and it's possible to put somebody into a deep level of sedation. And realistically, we don't want that in the hands of providers that are not trained to deal with patients like that. So I think that there are right settings for the use of ketamine, and there is this almost stigma associated with it where we're not really sure if we can use it. But as most of us know on this podcast, I imagine that a lot of you are excited about the use of ketamine and are using it frequently. So I think ketamine intranasally in the emergency department is an excellent option.
I guess my question, and I have not used intranasal ketamine very much, but my question is going back to that dose issue, right? Like, can you get enough in with 1 ml per nostril to make this work, to make ketamine work? Like, what dose do you need to use to be able to accomplish something for pain and procedures with ketamine? And does that work for the nose route since you can only use 1 ml per nostril?
It depends on what you're working with. So generally speaking, the dose is considered to be between 3 to 6 milligrams per kilo up to 9 milligrams per kilo. So in a small child, you can actually achieve that relatively easily because, you know, the dose is actually quite small compared to the volume that you can administer through the nasal passageway. It also depends on what ketamine you have available. Ketamine is available in 10 milligrams per ml, 30 milligrams per ml, 50 milligrams per ml, and 100 milligrams per ml. And so first of all, that's important to know, so that way you can facilitate an appropriate dose if necessary. But also, that also poses a significant safety concern because if you have multiple formulations available within your emergency department, it's possible you could get your hands on the wrong concentration and inadvertently give a small or large dose. So, depending on the concentration, depending on the patient, it definitely is possible to give them an appropriate dose depending on what level of sedation or pain control you're trying to achieve.
What about duration of action? Can I expect this to be similar to an IM or IV? Where do you put that?
I'd say you could consider it closer to IM, But in general, the analgesic effect is considered to be up to 60 minutes if you're giving an analgesic dose. Now, you may have a lot longer duration if you're giving a larger dose, or a smaller duration if you give a small dose.
What about the side effects with intranasal ketamine, Chris? Intramuscular ketamine is controversial. I personally don't use it because of the side effects that were associated, such as increase in nausea and increase in length of staying sleepy. But what about with intranasal?
Intranasal, to me, is most similar to an intramuscular injection of ketamine in that you still can see some of the same side effects. However, I also feel like because the absorption is lower, you may have a blunted effect associated with the ketamine. So you may not see nearly as much side effects associated with the use of intranasal ketamine, but it certainly still is possible. And I would say that we don't use it in our environment, so it's hard for me to say exactly what the rate is, but I'd say it's close to approaching what you would see in an intramuscular utilization of ketamine.
Just to say out loud, there is a downside beyond just the volume, but it is uncomfortable for kids to receive these medicines in their noses. And so, if you have an IV, I would say that it is better to use that IV. It's kind of like some of the other medications that we've talked about. This is a really good bridge or a short-term option, and that's how I use it predominantly. Like if I need it for a short procedure and they don't have to have an IV placed, or if they don't have an IV yet and I need something fast, that's going to work better than oral. Or if I don't want to do a poke and give them an intramuscular injection, or at home like naloxone and intranasal midazolam for seizures at home, those are both great options. But there is the downside that this is not comfortable.
Certainly upsetting to some patients, especially pediatric patients. But again, I agree with you. The simple, short procedures in patients where it may be dangerous to administer for both staff and faculty, that's a really serious situation where the use of a non-needle administration technique might be a useful option, such as our autistic patients that are stronger than our nurses, our providers, or our lift team, or in situations where you don't want to get IV access for simple or easy imaging. This is an excellent option. But I think you bring up a good point. This is upsetting to a lot of our pediatric patients.
Julia, you mentioned, having it at home for a seizure reversal, having a midazolam IN. Is there an advantage to giving the IN midazolam versus like a diastat rectally?
Not really. The administration of benzodiazepines for a seizure patient is considered a class effect. So if you're giving it via IN or intranasal versus IM, intramuscular, there really shouldn't be much difference to diastat versus midazolam. However, I have seen major differences in coverages associated with these medications, meaning that some insurances will not pay for diastat, surprisingly, and others will pay for midazolam intranasal, surprisingly. So it really depends on what insurances or what social scenario you're working with, but diastat is generally our standby option for at-home seizure treatment.
Well, I would argue there is an advantage because families are much more likely to just reach over and put something in the nose, like a nasal spray, than they are to pull their kids' pants down and give a rectal medicine, especially if they're in a public scenario. I see a lot of families that feel very uncomfortable with rectal medications in the United States.
That's a great point. And being a little bit removed from those patients as a pharmacist, I often forget about that. So no, if it's breaking down barriers, then I think that that's a great option for some patients.
Yeah, I think even in the emergency department, people feel much more comfortable with medicines in the nose than they do in the bottom, just in reality.
Parents, you mean?
Parents, yeah, and patients themselves. Yeah.
Chris, anything else that we should know about intranasal meds?
Intranasal medications are variable in terms of the availability at your shop, at your institution. So if you're working within a practice environment that doesn't have these options available, start looking into it, start addressing these situations or making requests to your electronic medical record director to have these agents in place. Increasing the options that you have available for these patients, such as our sickle cell pain crisis patients or our pediatric patients, is certainly in everyone's best interest.
I love that point, Chris. And whenever I'm doing community emergency medicine education, that's always one of my points too, is go home, talk to your pharmacy team, talk to your department director, whoever's overseeing operations, because this can be a real game changer for kids. Well, I think that about wraps it up. Thanks, Chris, for talking to us about intranasal meds. I feel a little more prepared for my next shift, so thanks.